6 o'clock, sir. Going to be. இது ஒரு ஃபோட்டோ எடுத்து டக்குன்னு காமிச்சு விட்றப்பா. ஃபோட்டோ எடுத்து அமிச்சிட்டு இங்கே வச்சுட்டு சைலண்ட் அப்படி வந்து வச்சுட்டு அவருக்கு அமிச்சு விட்ரு டக்குன்னு இருக்கு. 6 o'clock, sir. Shabri?
Dinesh, shall we start?
Five, 4, 3, 2, 1. We are live, sir.
Shall I start?
Yes, Dr. Kannan, sir.
Yes. Good evening, my dear friends. At the outset, I would like to thank you all. I am Dr. Kannan. I would like to thank you all for giving the great opportunity, and also I would like to thank the Sun Pharma Signals team for organizing this meet. Today we are having important topic to discuss, important topic to enlighten, important topic to entertain, that is so-called as fatty liver. We all know that fatty liver is one of the globally burdening disease. It prevails all parts of the world. Almost 25% of the global population are suffering from the fatty liver. Today's topic will be on more focusing on the non-alcoholic fatty liver disease. What is non-alcoholic fatty liver disease? That is the accumulation of fat in the liver parenchyma without the evidence of any consumption of alcohol. So it is called as non-alcoholic fatty liver disease. It has a wide spectrum complication with the morbidity and mortality. First, the term of NAFLD was first described in 1950, and then it was modulated and produced by Ludwig et al. In 1980 after having a lot of researchers. In our routine clinical practice, we are used to see a lot of fatty liver patients. Incidentally, we are supposed to see the ultrasound report, but after seeing the report also, we are not so aggressively treating the patient. But if the patient doesn't have any comorbidities, the patient only having the fatty liver means it won't produce any problem at least for 5 to 10 years. So if the patient having any comorbid like obesity, any diabetes, and any concomitant cardiovascular disease or hypertension, is all aggravating factor, triggering factor for the going for complication of fatty liver into a second stage like NASH and fibrosis and other complications. So the fatty liver is the spectrum of complication producing for the liver inflammation. So simple fatty liver is nothing but non-inflammatory process. This non-inflammatory process will lead to the liver inflammation process so-called as NASH. That is so-called as non-alcoholic steatohepatitis, and leading for this one liver scarring and ballooning, and land up in liver fibrosis. And this liver fibrosis is not intervened properly means they will land up in some other complicated dreadful disease like cirrhosis liver and hepatocellular carcinoma to some extent. We all know that globally we are having three problems. One is snacking, and the other is screen timing. Snacking, spending a lot of time in defensive snacking, taking a lot of junk food, fatty food transfer, that is focused snacking. Since the lockdown, 6 months or 7 months of lockdown, most of the patients are put on increase in weight without any proper diabetes control, hypertension control, because defensive snacking, increased snacking is one of the menace all over the world globally prevails. The next is screen timing. Screen timing is sitting solemnly in front of the screen, watching the TV, watching the media, or watching the cell phone. That is screen timing. The third is activity, physical inactivity. See, by having enhanced snacking, by means of enhanced screen timing, nobody following the rules and regulations of any physical activity. So these concomitant three factors are more main complicating factor for the fatty liver. So the fatty liver main predisposing factor are obesity, insulin resistance, and diabetes. These are the three cardinal factors. Insulin resistance will provoke the fatty liver. Obesity also will provoke the fatty liver, and also associated some other finding also will provoke the fatty liver. So it is one of the component of the metabolic syndrome. It is associated with insulin resistance, increased TGL, and uncontrolled hypertension and decreased LCL. So erratic food habits like increased fructose in the food also is important factor for the enhanced prevalence of the fatty liver. Urbanization and westernization. See, our children are more love for the this one junk food like pizza, burger, and cokes like that. These are all westernization foods. These are all main reason for the childhood obesity, adolescent obesity, putting up in silent fatty livers. Fatty liver is a silent disease and therefore also a silent killer. Apart from that, there is another factor called genetic factor. Genetic factor, we know about the two genes. The other gene also has been provided and presented in the latest ADA forum that we will discuss later. And hormonal factor. Hormonal factors like hypothyroidism, hypopituitarism, hypogonadism, also important factor to predispose for the fatty liver. And other factors so called sleep apnea syndrome and PCOS, etc., so on and so forth. See, so this is empirically combined of entero, hepato, metabolic, neurohormonal factors have been influenced for the protection of the fatty liver. So fatty liver is a silent killer, is a silent disease, prevails globally. So that should be intervened at the stage of fatty liver itself. Simple steatosis can be intervened and reverse the problem. If the patient gone for the NISH, can be intervened to reverse the problem to some extent. Once the patient entered into the fibrosis or scarring or ballooning, it's very, very difficult and become as a non-reversible phenomenon. For this topic enhancement, for this topic enlightened for the physician and clinician, we have a good speaker, a good dynamic speaker, a brilliant speaker, a vibrant speaker, youngest gastroenterologist in Chennai, that is Dr. Arun. I'm very, very happy to introduce and it's my pride and pleasure to introduce Dr. Arun. Dr. Arun is the assistant professor of gastroenterology. He's a Department of Digestive Health and Diseases, Chennai. He's a visiting consultant at Billroth Hospital, MGM Hospital, Chennai. He's the director of Chandra Gastro Liver Clinic and Endoscopy Center. And areas of interest have post-liver transplant, immunosuppressive guidelines, and plasmapheresis in the acute and chronic liver failure. It is a life member in the Indian Society of Endoscopy, and is a life member in the International Association of Study of Liver. Is a life member in the Society of Gastrointestinal Endoscopy in India, and is a life member of the Indian Academy of the Pediatrics. Today, Dr. Arun will enlighten us, will empower us on all the aspects of the fatty liver, what are the pathogenesis, what are the basics, how to prevent, what are the treatment modalities, how to prevent by means of lifestyle modification, how to prevent by means of dietary modification. Everything will be enlightened by the Dr. Arun. Over to Dr. Arun. Welcome.
Thank you, Dr. Kannan sir, for a reasonable, very brief introduction about me. And without you, the session won't be a complete one, sir. And Dr. Kannan sir is a leading consultant physician and diabetologist who is having a leading practice in Chennai. And thank you, sir, for spending your time in during this Sunday to discuss something about fatty liver during this current scenario. I'll be sharing my slides within a few minutes. Whether my slides are visible, sir?
Yes, sir, visible, sir. You have to zoom the slide.
Yes. So good evening, respected professors, senior consultants, and my dear friends. It's indeed a great pleasure for me to be along with you all during this terrible pandemic season to discuss something about the current epidemic, which is more prevalent, and we don't know what's happening because day in and day out in your daily practice, we'll be getting something about fatty liver. When we are seeing some patient, even if the patient is obese or even if the patient is not obese, the patient may land up in fatty liver. So incidentally, they may pick up fatty liver. With this fatty liver, how common you're going to diagnose a clinical scenario? How are you going to approach a patient with fatty liver? How are you going to intervene a patient with fatty liver? And what are the diet and lifestyle modification? If there is any pharmacological approach, and what are the recent updates, what's happening in the field of fatty liver? That is my area of interest to discuss with you all right now. And also I would like to thank Sun Pharma to give me an opportunity to share the knowledge of fatty liver along with you all in this forum. And as we all know, so NAFLD, if you're going to discuss, it's a leading cause of morbidity and mortality, which predispose to chronic liver disease throughout the world. If you're going to look into that, I mean, so see, it's going to predispose to multiple complications, and there will be multiple comorbidities going to happen because of that. It can predispose to cardiovascular disease. As we all know that non-alcoholic fatty liver disease is nothing but it's also the most common cause of death is mainly because of cardiovascular mortality, and the patient can have a diabetes, type 2 diabetes and other complications. The patient may develop metabolic syndrome. The patient can land up in obstructive sleep apnea because of obesity and vitamin D deficiency, because of bony pathology, and other common complications can happen because of this fatty liver. And if you want to discuss about the definition of fatty liver, it's nothing but, see, if you're going to see a liver by histological analysis, if there is steatosis, if it is going to be more than 5%, which is going to be involved. And also by recent investigations by MRI spectroscopy, if you're going to see a proton fat density fraction of more than 5.6 assessed by MRI, these are the newer definition as per AASLD statement. AASLD, American Academic Society of Liver Disease, what they've been given the guidelines about this. See, any disease, if you're going to discuss about a fatty liver, it could be because of alcoholic, it could be because of non-alcoholic. If you're going to see because of alcoholic, it will be predisposing to. If you're going to discuss about alcoholic, around 90 to 100% of the patient will be having fatty liver if the patient is going to consume alcohol for a period of time. And my area to discuss, even if the patient is non-alcoholic, if the patient is having metabolic syndrome or other coexisting complication, so if the patient is going to present with fatty liver, how does it going to progress? What is the semiology of event? What is the natural history of this disorder to worsen? See, as we all know that the commonest presentation is steatosis, nothing but fatty liver, and this fatty liver in few percent of the population, if the patient is having inflammation, which is going to be persistent, and it can go for a non-alcoholic steatohepatitis, which is further worsening state in which liver enzymes, the clinical activity will be worsening, the histological parameter will be worsening, all those things will be worsening in these kind of patients. And once a patient develops NASH, there is around 4 to 20% of the possibility for this patient to go for a severe fibrotic changes, which is nothing but cirrhosis, and for the patient can go for decompensation over a period of around 8 to 10 years, the further progression. So this steatosis will progress you for multiple complications if you're not going to control at an earlier point of time, if you're not going to intervene early. And this will predispose to death because of cardiovascular. It's the most common cause of morbidity. Most common cause of mortality is nothing but because of the cardiovascular events, and also because of the second-related malignancy. See, if you're going to think about the liver-related focus, is only 1 to 2% of the focus will be having death because of this hepatic steatosis. And you should remember that there are other progression. Hepatocellular carcinoma is one dreadful malignancy, which is also more common, can be reported. This is about the global prevalence. Around 25% of the world population will be having a non-alcoholic fatty liver disease. And if you're going to look into this, this is the spectrum. What you're going to discuss, nothing but, see, if there is no evidence of hepatocellular injury in the form of ballooning or no evidence of fibrosis, nothing but fatty liver, non-alcoholic fatty liver. But if there is steatosis with ballooning, with or without fibrosis, nothing but NASH. So if you want to say NASH, you need to prove the patient by a histological diagnosis. That's the most important to confirm the diagnosis of NASH. So if you want to about and if you are going to look into the Asia, around 27% of the patients will be having preponderant. Actually, initially it has been discussed as a disorder more common in the Western population, and now it is being available. It's being more common in our Asian society also. Even Middle East and Africa, Middle East and American population is also being reported more. And nowadays, even India, the prevalence is almost will be more in case of in our southern part of India, it will be almost touching up to 30%, and in northern part of India, it's going up to 53%, and western up to 16, and in eastern part of India, it's going up to 24%. So this is an interesting discussion by Professor Mehta et al. Like, can alcoholic liver disease and NAFLD can coexist? So we have been seeing some patients who used to consume alcohol being presenting with metabolic syndrome, and who have been seeing some patients with non-alcoholic, but they'll be consuming few doses of alcohol. If this kind of presentation is going to happen, always you should remember NAFLD and alcoholic liver disease can also coexist. Even if you want to say the patient is having NAFLD, there are certain criteria to be, see, the patient alcohol consumption should be less than 20 grams per day in the case of female, or less than 30 grams per day in the case of male. That is the most important entity to be added into the discussion if you want to discuss something in favor of NAFLD, along with evidence of metabolic syndrome and other parameters to coexist. And this is one very interesting new paper I would like to quote along with you all. So this is nothing but MAFLD. See, now the new nomenclature has been taken into account. What is this? Metabolic associated fatty liver disease. Now, non-alcoholic fatty liver disease is no more in use. Now it has been worked on. The new nomenclature has been taken as MAFLD. If you want to describe, it's nothing but it's alcohol predominant fatty liver or non-alcoholic fatty liver. This is a major entity in which the MAFLD is going to divide. So this is a journal of proof. If you want to have a overlook, this is such a big area to discuss, and as the time not permitted, I'll be winding up in the next slide. See, why NAFLD is epidemic in India? Because we don't know what's happening. See, and we have been seeing with the patient with insulin resistance, hyperinsulinemia, metabolic syndrome, diabetes, obesity, dyslipidemia. All this phenomena we will not be able to understand most of the time. When the patient presenting us, we'll be diagnosing most of the time, and only once the patient develops complications in the form of NASH or diabetes, non-alcoholic steatohepatitis, you can able to see NAFLD in the tip of the iceberg. That's the most common scenario. That's why this being an epidemic, which most of the time we couldn't able to recognize when we are coming across with this kind of presentation. So as we all know, diabetes, insulin resistance, and hypertension and weight gain, if there is a persistent weight gain, those things and all I'll be discussing to you in my upcoming slides. And ALT, AST, AST to ALT, if it is going to be more than one, these are all the parameters for worsening of the disease progression. And less than 4% will progress to cirrhosis if the patient is having non-alcoholic fatty liver. And if the patient is having evidence of NASH, there is high possibility for this kind of patients to go for cirrhosis. So NASH, we need to prevent the patient developing NASH. We need to control the patient's fatty liver. The diet and lifestyle modification has to be taken into account in a proper way. See, if you're going to discuss about the pathophysiology, it's such a complex phenomena to understood. So, but I would like to discuss very few things about the pathophysiology. As we all know, the circulating free fatty acids is the one thing which is going to be exceed. If the circulating free fatty acid is going to get exceed, what's going to happen? See, as we all know that the fat is going to accumulate in the liver. So the lipolytic action, so the insulin resistance is the most common phenomenon being reported in patients with NAFLD. So once the insulin resistance is going to set in, what's going to happen? There will be the anti-lipolytic action of this insulin will not be there. So anti-lipolytic action of insulin, if it's not going to be there, the circulating free fatty acids is going to be more. Once the circulating free fatty acids is going to accumulate, which will predispose to multiple fat accumulation, and this will predispose to fatty liver, and this will predispose to multiple phenomena, oxidative stress, multiple damage. See, if you're going to look into this, it's the two hypotheses in each frame, and nowadays even the multi hypothesis, even one phenomena we couldn't able to take into account. Multiple pathways are being involved in the pathogenesis of non-alcoholic fatty liver disease, in which I'm brushing you the basic, outlining you the concept, basic concept, what you're supposed to know. So in this, the insulin resistance will be high, the free fatty acid influx and decrease in free fatty acid oxidation, and TGL export, reduction of TGL export, and the adiponectin, which is one of the most important hormone which is being predisposed, the reduction of adiponectin, all this will be preponderant to steatosis. What is going to happen once this phenomena, insulin resistance is going to happen, there will be free fatty acid, FFA oxidation will be incomplete, the hepatocyte, apoptosis will be sitting in, the multiple cytokine pathways is going to be activated, multiple necrosis, tumor necrosis factor, interleukins, leptins, all hormones is going to release, and the adipokines levels is going to go down, and multiple pathology is going to involve in this, the apoptotic pathway activation, the oxidation, the PNPPL, which means palatine-like peptide. So many pathology is going to be involved in this concept of non-alcoholic fatty liver disease. So insulin resistance, metabolic syndrome, activation and interaction between the multiple events, the first aid, second aid, and third aid. So the normal liver going for steatosis, from NASH to fibrosis. This is the most important entity, and all the cytokine toll-like receptor overexpression, apoptotic activation. That's why there are multiple newer modalities to discuss about the management of the fatty liver in a nutshell. So what is going to happen? Once this unhealthy dietary lifestyle is going to intervene, so what's going to happen? The gut epithelia is going to be disrupted. The PAM, nothing but pathogen associated molecular pattern, and all those things is going to be activated in your gut lumen, which will predispose to gut dysbiosis and gut microbiota, and all those things will be forming. That's why there is some role of probiotics, as we have been discussing in the upcoming slides. So dysbiosis is going to set in, and this will predispose to increase multiple receptors and de novo lipogenesis. You should remember that not only because of the free fatty acid accumulation, also because of DNL, de novo lipogenesis, which is going to set, and also because of the excess dietary consumption. If you're going to consume, don't think that only if you're going to take fat, you're going to have fatty liver. If your carbohydrate is not in a good proportion, if you're going to consume plenty of carbohydrate, that too will predispose you for development of fatty liver and fatty liver complications, other things to set in. So once the free fatty acid is going to elevate, the leptin, resistin is going to build up, and the adiponectin levels is going to come down, and which will predispose to increased visceral fat accumulation, and insulin resistance will be augmented, and this will predispose to non-alcoholic fatty liver and NASH to encounter. So this is the outline what I'm discussing. So once hepatic steatosis is going to set in, the patient is going for cell death, which is nothing but necrosis, necroptosis, apoptosis. All these pathways is going to be the mitochondrial dysfunction will be there, oxidative stress because of the various interleukins and cytokine pathway, and because of the endoplasmic reticulum stress, and all these things will be activating the pro-inflammatory signaling that will activate the hepatic stellate cells, and which will make the patient to go for collagen. More of collagen gets deposited. Once the collagen gets deposited more, the patient can go for fibrosis, cirrhosis, and nothing but finally the patient can land up in hepatocellular cancer. That's the most important thing. How to recognize the patient is going for NASH? So now fatty liver is the incidental diagnosis. You are going to pick up the patient, but once the patient, most of the patient will be having no symptoms, and incidentally when you are going to diagnose this fatty liver, and once a patient develops complications of NASH, non-alcoholic, the patient can predispose to hepatomegaly, and some patients will be having AST-ALT ratio, will be going to be liver enzyme alteration, but most of the time liver bilirubin, albumin, phosphorothrombin will be normal, unless and otherwise if the patient is going for decompensation. So the vague abdominal pain, fatigability is the most common presentation. Doesn't mean that fatigability not only report another complication. As we all know, any patient who is going for evidence of cirrhosis or chronic liver disease, or any patient who is going for evidence of non-alcoholic, kindly mute down kindly mute all. Or once a patient is going for fatty liver, or once a patient is having fatigability, there is high possibility for the patient to go for NASH and cirrhosis and malaise and other things, and to set in. So these are all the various associations that's more commonly encountered. That's what been discussed in my initial slide, like PCOD, hyperuricemia, adenomatous polyposis, cardiovascular is the most common complication. That's why the Diabetic Society, Endocrine Society, also the Gastroenterological Society, all together form multiple guidelines are there that are, since the time is not permitting, I couldn't able to discuss all those slides. If you're going to discuss all those things, even the hypothyroid, even the thyroid, if you're going to control the thyroid in a good manner, even if you're having excess or reduced thyroid levels, the thyroid, if you're going to control in a good manner, the levels of fatty liver is definitely going to improve, and elevated ferritin is a pro-inflammatory marker, and so many other comorbid conditions going to associate if the patient is going to have evidence of fatty liver disease. So what is the preponderance? Suppose if the patient is having diabetes mellitus, so what is going to happen? So this will also bring a synergistic effect. So if the patient is having diabetes, the worsening of NASH will be 3 to 4-fold. If the patient is obese, NAFLD, insulin resistance, the patient worsening all those factors, if it is there, the 14-fold worsening of elevations will be there. But once the patient is having only diabetes, what's going to happen? If the patient is having diabetes, there is high possibility for this patient to go for NASH, and the patient to go for cirrhosis and other liver diseases can set in. So how to diagnose? How will you recognize this NASH? See, based upon your metabolic syndrome parameters and based upon the lab parameters. So if you're going to take hypertension and diabetes along with the altered liver enzymes and sleep apnea, so you're going to take all those parameters. If the patient's points is in favor of more than 6 to 7, there is high possibility of morbidity because of NASH is very high for this. See, once you're going to label the patient as fatty liver, always you need to think about the various diagnoses. Don't think that only alcohol or because of non-alcohol. That we need to look for the multiple other etiology. The other etiology I'll be discussing with you all in the upcoming slides. but always you need to diagnose. NAFLD is only a diagnosis of exclusion. You need to look for hepatitis B, you need to look for hepatitis C, you need to look for alcoholic events, you need to look for other coexisting pathology. It could be because of autoimmune, it could be because of Wilson's. There are multiple events that to predispose the patient for fatty liver disease, but non-alcoholic fatty liver, if you are going to label the patient, even after ruling out all the possible etiology, it's always a diagnosis of exclusion. That's the most important thing you need to consider. And the alcohol consumption should not exceed more than 30 in men, more than 20 in women. So we need to identify the risk factors. We need to exclude other etiology also by imaging modality. And finally, we need to subject the patient for liver biopsy. Who are all the patient been indicated that I'll be discussing to you. So alcoholism, autoimmune liver disease, Wilson's, viral hepatitis, and hemochromatosis, all those things to be excluded in your clinical history and based on lab examination. With this finding, you need to think whether the patient is progressing to non-alcoholic fatty liver disease or steatohepatitis, whether it's worsening or not. We need to think in terms of like that. So always we need to look for other possible etiology for steatosis. What are the other possible? Alcohol consumption is one possibility, and malnutrition, medications, parenteral nutrition, as I discussed with you, Wilson's and other diseases, so many other fatty liver coexisting pathology. You need to look into that to label a patient with non-alcoholic fatty liver disease. So, and this one new entity is being very few, and I would like to discuss with all the physicians, all the gastroenterologists will be looking into that. And this is nothing but the fibrotic score. There are plenty of, see, if you're going for the fibrosis measurement, the FibroScan, we need to look for the liver stiffness, LSM measurement. Liver stiffness has to be assessed through the probe. And with the liver stiffness, we can able to identify it's a non-invasive modality to diagnose your fatty liver and other pathology for this non-invasive modality. And we can postpone the liver biopsy, and we can able to come to the conclusion, even with liver biopsy, some patients we can able to identify whether the patient is going for NASH and other pathology. And there are plenty of surrogate markers for fibrosis, nothing but NAFLD related NAFLD fibrotic score is there, 5-4, and the ELF is nothing but enhanced liver fibrosis. There are so many fibrotic scores are there. And my intention is not to discuss each and everything. If you're going to look into this fibrotic scores, which is nothing but, there are plenty of tests. One is BAR, NICE, NASH, NAFLD. So always remember that NFS is most important: age, BMI, AST/ALT ratio, platelet count. Always you should remember APRI. What is APRI? Is nothing but AST to platelet ratio index. If this index is altered, that's a clear point here. Most of the time can be taken. It's a very bedside, easy measure to assess whether the patient is going by evidence of fibrotic liver, fatty liver disease is there or not. So there are so many surrogate markers to be looked into that, and fibrosis test, BAR, NICE, which is so many newer tests being used to diagnose this fatty liver disease. And some, apart from that, in higher investigations like elastography, there's measurements also we can do in kilopascals. We've been introducing the frequency of vibrations to the tissue, and we can assess the liver fibrosis. So if the patient is better for cirrhosis than for advanced fibrosis, you can use this transient elastography and MR elastography. So many elastographies are there, and VC, so many elastographies are being there in the field to diagnose, but it's very costly assay, and moreover, it's very difficult for all the patient, and it's very difficult to use in most of the centers. And moreover, without that also, we can able to diagnose a patient with evidence of fatty liver disease and other NASH and other complications. And there is high limitation for this presentation, like obesity and other complications can also, if the patient is having obesity and other things, it will be it's very difficult for you to look for the FibroScan. And sometimes if the patient is having high bilirubin, so that high bilirubin values also it's going to alter, and it's very difficult for you to use a FibroScan in those kind of patients. And if you are going to look for the multiple biomarkers are there, like cytokeratin 18, see nothing but it's apoptotic fragment. It's derived by the apoptotic cell death. So if you're going to look for the cytokeratic fragment, cytokeratin 18, you can able to diagnose NASH is there or not. And also you can able to diagnose by M65 ELISA, M30 ELISA. So many newer surrogate biomarkers are being available to diagnose this fatty liver disease, which is very upcoming in the field of hepatology. And next to that, and so always the identification of advanced fibrosis or cirrhosis by biomarkers, elastography, and fibrotic scores, it's more important. And also the clinical and also the clinical prediction is most important to diagnose the patient with evidence of fatty liver disease. So if you are going to look for ultrasonography, the sensitivity is going to be around 60 to 90, and always you need to look for the aquatic shadows and other thing. And CT, if you're going to slightly more costly investigation, if you're going to do a CT, always you should remember 3 pointers in CT, but it's not absolutely indicated for all the patients. It will enhance hepatic attenuation, and if attenuation value, if it is going to be less than 10 ounce per units in compared to the spleen, or liver to spleen attenuation ratio, if it is going to be less than 1. So these are all the pointers to consider whether the patient is having evidence of fatty liver disease in CT. And MRS, as I've been discussed with you in the initial diagnostic slide, if the MRS, if the liver fat fraction, so by hydrogen content, you need to assess the liver fat fraction. If it is going to be measured, if it is going to be more than 5.6, it is almost the sensitivity is very high. It is going to be around 90 to 95% if you are going to use MRS in diagnosis. And always you should remember, the liver biopsy is one of the gold standard to diagnose a patient with NASH. So if you want to use liver biopsy, so how will you differentiate? So what are the things you need to look for liver biopsy? We need to look for steatosis. We need to look for steatosis with lobular inflammation or portal inflammation, or with ballooning is there or not. So always we need to do a liver biopsy if you want to completely look into the diagnosis, and along with that, the portal inflammation, mammary dengue bodies, apoptotic bodies, so many other fragments to be assessed in case of fatty liver. And if you're going to, and there is a histological scoring system, nothing but more than theoretical point. See, based upon the steatosis and lobular inflammation and hepatocyte ballooning and fibrotic stage, you can able to severity of NASH. And why we need to do this liver biopsy? See, if the patient is having evidence of chronic liver disease, if the patient is going for cirrhotic background, if the diagnosis, if you couldn't able to establish, and if the age of the patient, if it is going to be more than 45, the first time of presentation, a worsening of events, a rapid worsening of AST-ALT ratio, these are all the other parameters to always to be considered if you want to look for the NASH histological scoring system. So also, apart from the liver biopsy, if you're going to look into the liver biopsy, AASLD has come out with the multiple guidelines for that. And you can also do a stool test, which is not much of use. If you're going to look for stool, so as we had discussed, the role of probiotic is going to come here. The proteobacteria and few firmicutes is there in the stool in early stages of NAFLD. Nothing much of significance. And this homeostatic model assessment can be used to assess as a surrogate marker in patient with diabetes. So what they are going to use, if you're going to look into the fasting insulin and glucose levels, if it is going to be more than 1.8 to 2, what does is going to implicate the progression to fibrosis. If the patient is going to fibrose in an earlier way, we can able to assess the patient in a rapid way. And these are all can be used as additional pointers to diagnose the patient with early diabetes and worsening of NASH and fibrotic progression is there or not. So this is a key, outline of all the things what's been discussed right now. So we need to assess whether the patient is having evidence of steatosis is there or not. And if the patient is having steatosis, we need to, with liver enzymes, if everything is fine, if your FibroScan is normal, just follow up the patient. But if there is any abnormality in your liver enzymes, if there is any pathology in your FibroScan, if it is going to be assessed, then the patient needs a specialist referral. And even if the steatosis is absent, we need to follow. If the liver enzymes, everything is fine, we just follow once in 3 to 5 years to assess whether the patient is worsening or not. So always you should remember, once a patient develops NASH, the 10 years survival is going to come down around 20 to 30% of the patients. And in alcoholic steatohepatitis is still worsen, will be only around 15%. So the most important parameter, the most important entity for me, apart from the diagnosis, the clinical presentation, the pathophysiology, what is the new updates, what is the basic thing you're supposed to know in managing a patient with non-alcoholic fatty liver disease. This is a wonderful slide from Professor Duseja from PG Chandigarh. If you're going to look into this slide, what's been discussed, he has taken the foremost to say always you risk for the metabolic parameters, metabolic syndrome is there or not. Suppose if it is there, we need to take diet and lifestyle modification, exercise, control your hypertension, obesity, dyslipidemia, always everything to be taken, and look for evidence of AST-ALT alteration and decide whether the patient needs liver biopsy, is there or not. If the patient decides liver biopsy, whether the patient fitting into the diagnosis of NASH is there or not, based upon that, we need to initiate the patient with therapy. See, always see if the patient is having evidence of NASH in the background of non-cirrhotic. So once a patient develops cirrhosis, always you should remember there are multiple drugs. But if in fatty liver, many of the general practitioners and physicians, and even some gastroenterologists will be using frequently UDCA, and you'll be using frequently vitamin E, and so many other molecules you'll be using. So where the molecules? So once a patient develops liver cirrhosis, the role of vitamin E is not much. And once a patient is having biopsy-proven severe NASH, the role of vitamin E is not, can be considered. And these things and all can be used to as per Professor Duseja's statement. So there are in this area, all this pathway is going to be affected. Based upon this area, there are new upcoming molecules are being discussed, like lifestyle interventions, as I discussed with you, insulin sensitizers like metformin and other things, role of probiotics and multiple antioxidants now in trial, and pan-caspase inhibitor and antifibrotics, all those things I'll be discussing to you all in my upcoming slides. If nothing works, once the patient develops NASH and steatosis, steatohepatitis, and this can be considered for the patient for liver transplant. So what is the first thing you need to take care of? Diet and lifestyle modification. That's the most important thing. So diet means don't stop only fat, cut down your carbohydrate also. So if you're going to restrict your diet, so high dietary carbohydrate, what's going to happen? It's going to promote your de novo lipogenesis, free fatty acid accumulation. That is also very lipotoxic, and it will also predispose to multiple other complications. So always you should reduce your carbohydrate in your diet, and fat also to be reduced. And most commonly, you need to follow a Mediterranean diet-like pattern. What's like that? It's rich in fiber and high in monounsaturated fatty acids. That's why we are supplementing some patients with omega-3 and monounsaturated fatty acids is going to be high. So what is going to happen if they move on? Other things is going to be increasing your diet pattern. Will definitely bring down the steatosis and fibrosis. And see, this is what is nothing but the outline of Mediterranean diet based upon the carbohydrate as well as your fat. That's the most important thing in dietary pattern to be considered. So if you are going to, based upon, see, look at the journal, World Journal of Hepatology, what they've been discussing. If the lifestyle modification is good, it definitely is going to improve your insulin resistance and liver histology. It's going to be improved significantly in patients with non-alcoholic fatty liver disease. So there are, as I discussed with you, based upon the, these are all the various trials being given. Phrase it all. So many trials been discussed about the diet pattern and diet. See, in all this study, what they have been discussing, the liver enzymes. If you're going to adhere to the strict diet pattern for a period of around 6 to 12 months, definitely the liver enzymes, the stiffness, everything is going to improve, and your clinical status is going to definitely improve. The diet pattern is going to be very good. This is also the same side. Based upon your diet and lifestyle modification, the diet of choice, you need to continue for years, but rather than for weeks. You need to adhere to the diet pattern. That's the most important thing. The physical, see, and one more thing in the diet I would like to discuss. One of my professors used to discuss it frequently in his presentation. If you're going to take coffee frequently, if you're going to take around 4 to 6 cups of coffee in a day, there is high possibility for you to prevent the progression of non-alcoholic fatty liver disease, because unsweetened filtered coffee is definitely going to have a significant benefit, because it's going to have a protective effect from your metabolic syndrome, and it reduces the liver injury as well as development of fibrosis as well as a progression of the patient to HCC. So this is on paper what been discussed about the caffeine consumption and non-alcoholic fatty liver disease. What they've been discussing, the regular caffeine consumption over a period of time is definitely going to improve your liver fibrosis, but doesn't mean that the coffee is going to have a significant impact. But it's a theoretical point to discuss. If you're going to consume coffee a lot, the possibility of non-alcoholic fatty liver are slightly low for this kind of patients to be in frame. And next to that, the most important thing, you're exercising. Are you exercising or not? If you're exercising, how many times, how many days in a week you're exercising? You need to follow an aerobic exercise pattern. Aerobic exercise means in the form of jogging, swimming, running. These things has to be adhered to in a proper way. So if you're going to be there, you need to do a minimum of approximately 150 minutes in a week, or at least 30 to 45 minutes per day for a period of at least 5 days. And in India, if you're going to look into the data, if you're going to do this exercise and only 10% of the population, less than 10% of the population is going to adhere this kind of exercise and diet modification for a period of 6 months. And very poor data have been reported. And we are all not being engaged frequently in diet and lifestyle modification. That's the most important phenomena to be taken into account for managing a patient with non-alcoholic fatty liver disease. See, in this study, they've been considering, so if you're doing exercise means how to exercise. See, you need to improve. See, always you should target your heart rate. Your heart rate has to be, see, if you want to calculate your maximal heart rate, how to calculate your maximal heart rate? You 220 minus age. Suppose if you are around 30 years, you need to target your heart rate 220 minus age, and it comes around 190. So you need to target your heart rate at least 60 to 70% of your maximal heart rate. So that is the most important thing when you're exercising. So you need to exercise in such a way to improve your heart rate, and that will predispose, that will improve, ameliorate, that will reduce your insulin resistance and reduce your hepatic vessel fat and will predispose to significant weight loss. Those are all the things which will be more important if you're going to tackle a patient with NAFLD. So these are all the various studies that have been pointed out about exercise interventions in NAFLD. And with all these trials, all they've been discussed, if you're going to do a regular physical activity, dieting, exercise, and definitely your fibrosis and liver fat content, it's going to definitely improve if you're going to do aerobic exercise. If you're going to do aerobic, and if you're going to measure the liver fat content by MRS, there is a significant improvement being noted by exercise intervention. That's why diet and lifestyle modification is the most important thing to be taken into account when you're tackling a patient with non-alcoholic fatty liver disease. So this is a very old slide with 2016, what have been discussed. See, if you're going to lose around 3%, the steatosis definitely is going to come down. And ballooning inflammation, if you're going to lose around 5% of the weight, is going to improve. And if the patient loses around 7%, NASH is going to improve. And if the patient is going to lose around 10%, there is definite progression, definite improvement of fibrosis also, around 45% of the patients. So always the weight reduction chart, weight reduction, this is the tapered diagram, which has been most important pyramid to be followed in management of weight reduction protocol. So follow a hypercaloric diet, you reduce your sugar intake and don't take plenty of complex carbohydrates, and increase your PUFA in your diet. As I discussed with you, aerobic exercises to be done, and nutraceuticals like coffee, other antioxidants, some probiotics, those things and all can be considered if you're managing a patient with non-alcoholic fatty liver disease. So what is the role of bariatric surgery? See, bariatric surgery is not the main concern, but definitely there is some role. But in India, how far it is successful, it's a questionable issue. But how many percentage of patients being used for this bariatric surgery? If you want to say that only 1% of the patients going for bariatric surgery. So if the patient is going for bariatric surgery in NASH, so the possibility of improvement is definitely being there if the patient is having metabolic syndrome with morbid obesity. So morbid obesity, if you want to calculate the BMI, if some patients, some categorization, if the BMI, if it is going to be more than 35, and some categorization, if the BMI, if it is going to be more than 40, based upon that, the bariatric surgery can be considered like band, balloon, and the sleeve gastrectomy. Multiple modalities are there, even endoscopic approach, endoscopic bariatric surgical approach are there. So based upon that, all these things can be considered, but the beneficial effects is going to extend beyond the weight loss, and changes in the gut hormones, particularly GLP-1, insulin sensitivity, and lipid metabolism, all can improve apart from your histological features of NASH. Everything can be considered in bariatric procedure. But how far it is successful based upon multiple studies in this trial, what have been gastroenterology journal of what they've been discussed in 380 patients if they're going for bariatric procedures. And 1 in 5 years, if you're going to look for ALT, GGT, IR index, insulin resistance index, all these things, if you're going to look into that, there is a definite significant improvement over there. But how far we are going to look for bariatric procedures, it's almost less than 1%. That's the one drawback. And we need to maintain this, the study, it's very lagging in India. And moreover, we need to maintain a data for almost around 3 to 5 year follow-up is needed for this kind of patients before and after surgery. That is why this bariatric procedure is still not more validated to be considered. So, so this is one basic about, so discuss about endoscopic approach. Briefly, this is nothing but intragastric balloon. If you're going to base intragastric, there are multiple balloons are there. It's not my area of interest to discuss with you all. So one is Arboro, one is reshaped DO. There are so many balloons are there. If you're going to place your balloon, what's going to happen? It is going to augment. It's going to fill up your stomach capacity and your gastric capacity is going to come down, followed by you may predispose to reduction of weight. And it's once a patient is going to have an intragastric balloon, the enzymes, NAFLD, histological scoring, steatosis index, everything is going to improve. So based upon this, right, lifestyle modifications, bariatric procedures, and endoscopic and bariatric surgery, and after that, the main entirety of drugs. So if you want to take care of drugs, see, there are multiple drugs. No single drug is proven to be much effective in case of NAFLD, but there are multiple drugs being considered, but usually we'll be using the common drugs like vitamin E, pioglitazone, like that. So always, if you are thinking about pharmacotherapy, once a patient develops NASH and other complications, the role of pharmacotherapy is slightly high rather than if the patient is presenting only with non-alcoholic fatty liver. So once a patient started on pharmacotherapy, the progression of NASH will be around 7.1%, and progression of fibrosis by stage 1 will be 7.1% in NASH, and it will be only 14% in non-alcoholic fatty liver. So there are multiple medications are there. One is because of the anti-diabetic multiple medications, and another one is vitamin E, and so many other newer molecules that I'll be discussing with you all. And if you want to discuss about metformin, see, it's nothing but a bigonate. It's a protein molecule which is going to be used in the management of type 2 diabetes. So if you're going to use this bigonates, there are multiple papers to compare the efficacy and study. So what's going to happen? It's going to activate the AMP kinase pathway, and the inhibition of gluconeogenesis and hypogenesis is going to be there, and beta-oxidation oxidation is going to be in favor, and glucose uptake, fatty acids. As you all remember, the glucose and fatty acids is going to predispose. So gluconeogenesis and glycogenolysis is the common pathway is going to be involved in this kind of fatty liver pathology. So always insulin is going to be, this fatty acid and glucose uptake is going to be augmented, and that's why the metformin can be considered, but it's not been recommended as a specific treatment for NASH. And it's not having a significant impact on liver histology if you're going to substitute the patient with metformin for a period of time. And weight loss and insulin sensitizing properties is still more validated if you want to consider metformin as per Journal of Hepatology in 2016 to be mentioned. And this is another interesting molecule, thiazolidinons. If you're going to consider, it's nothing but it is going to activate your PPAR. What is the PPAR? It's peroximal proliferative activity receptor. If you're going to activate your PPAR, what's going to happen? It's going to locate in multiple areas, liver, muscle, adipose tissue, and many areas. So always you should remember the glucose is going to be dependent and the fatty acids is going to be accumulated. If you want to have all these areas pathway, it will be involving adipocyte differentiation, and fatty acid synthesis is going to be inhibited. As I discussed with you, the adiponectin levels is going to be high. And this one classical molecule, pioglitazone, if you're going to use at the dose of around 30 milligrams per day, there is some reasonable improvement if you have been using this patient, but if you are going to use pioglitazone, what the main indication as per the AASLD statement, what they are mentioning that biopsy proven non-diabetic, non-cirrhotic patients you need to use. So if the patient is diabetic, the usage of pioglitazone is not much considered. And also if you're going to use vitamin E, if the patient is having diabetic and a background of non-cirrhotic, not to be used much. And see always, so you need to prove that biopsy proven non-diabetic, non-cirrhotic NASH, if you want to use pioglitazone, can be considered as a second-line treatment. And so this is about when you're going to use the pioglitazone, the various levels is going to come down. And apart from that, the histological injury, the histological changes, everything is going to improve over a period of time if you're going to substitute the patient with pioglitazone. And steatosis, fibrosis, everything is going to improve. But one common side effect, you should always remember that the cardiac effects. Next to that, the fluid retention, the patient can develop edema, the patient can develop obesity, weight gain, and the patient can go for anemia and fractures. And sometimes some patients can go for increased cardiovascular mortality. So outlining all this benefit, outlining all these side effects, we need to consider whether it's thiazolidinons can be considered for a longer duration of time is still a questionable issue in the management of patients with non-alcoholic fatty liver disease. And next to that, alpha glucosidase inhibitors like acarbose and other drugs, but nothing much to discuss. This is just to outline. It also can be tried, but not much of use. And vitamin E is important to discuss, because if you're going to substitute vitamin E, the various doses are there. Some patients they'll be giving 400, some patients they'll be giving 600, and some patients if you're going to give around 800 milligrams. So always you need to use, and in NASH related patients, the role of vitamin E is still more considered. Non-diabetic patients still more considered. So what's the role? Multiple multiple trials are being there. So vitamin E, if you're going to substitute, it is going to reduce the cytokine production, and the stellate cell activation is going to come down and replete the glutathione. As we all know that the glutathione is one potent antioxidant molecule which is going to be involved not only in paracetamol and other poisoning. If it's be completely involved in multiple, even for this COVID and other issues, the role of glutathione is still more validated. So if you're going to give vitamin E, it will be involved in replenishing of your glutathione stores. So along with your diet, exercising, vitamin E, if you're going to consider for a period of time, along with ascorbic acid in this trial, what they been discussed, the beneficial effect, if you're going to use only vitamin E, not much, along with all those drugs, there is a reasonable around 20% of the decrease considered. Apart from that, a improvement of liver function and glucose, along with diet and physical exercise, along with vitamin E, if you're going to use, can be considered. So in this study, what we use around 600, these are all the various trials we use vitamin E. If you're going to look into this, very interesting trial, what's called PIVANS. If you're going to substitute vitamin E along with pioglitazone, so what they've been mentioned in that they have been taken, but the one problem is this, they have been taken the patient without diabetes. So there is no diabetes for this patient to be taken into account. And in this, they didn't show any significant change in fibrosis. If you are going to consider, vitamin E along with pioglitazone for if the patient is non-diabetic along with non-cirrhotic background. So if you're going to use vitamin E for a longer duration, the one common adverse effect always you should remember prostate cancer and sometimes hemorrhagic stroke. But these are all a very, very few patients, early case reports been reported, but still more considered in managing a patient with non-alcoholic fatty liver disease, a biopsy-proven NASH. So 800 international units up to that can be considered as always a first line of therapy as per Journal of Hepatology 2016 statement, and improves liver histology most of the time. So you should not use vitamin E if the patient is having NASH in diabetic and NAFLD without liver biopsy, or NASH cirrhosis or cryptogenic cirrhosis. So always remember, cryptogenic cirrhosis, the cause of cirrhosis, if you couldn't able to establish, don't use vitamin E. And if the patient is having NASH, don't use vitamin E. In diabetic population, not much of use. And when the patient develops cirrhosis, not much of use. So this is very common phenomena. UDCA, frequently they'll be using. Now the usage of UDCA in non-alcoholic fatty liver disease, once a patient develops NASH and other complications, not more used, it's not more considered. So the usage of UDCA is not more considered in the management of non-alcoholic fatty liver disease. It's a natural hydrophilic bile acid. It can be anti-inflammatory, anti-apoptotic, but it also exerts a farnesyl receptor antagonist activity. So what is nothing but farnesyl receptor? It's a very interesting area that I'm going to discuss about obeticholic acid in the management of fatty liver disease. So if we are going to discuss, UDCA also exists FXR antagonist effect on bile metabolism in morbid obesity. See, there are so many papers, if you want to try a minimal improvement of ALT, other things is there, but the recent statement, what they have discussed, the usage of UDCA in NAFLD, it's not more validated nowadays. Apart from that, statins, always when you're using statins, we will be having a doubt whether it will predispose to any statin-induced liver injury, other things, but definitely there is some usage for statins in the patient is having evidence of non-alcoholic fatty liver disease. Atorvastatin and pitvastatin, other things definitely is going to improve your liver steatosis and fibrosis, and hepatic triglycerides level is going to come down. So we can consider statins to a reasonable extent, but considering we need to monitor the patient for worsening your liver function and other pathologies there or not. So apart from statins, in this trial about hyperlipidemia, so many other drugs like fibrates, gemfibrozil, estimumab, everything can be discussed, but these are all nothing much of effects in the management of patient liver disease, only to control hypertriglyceridemia, but these are all not proven benefits has been established, especially for a statin we can use at a reasonable extent if you want to manage a patient with hyperlipidemia in NAFLD background. These are all the various trials being used to compare. So lack of time, I'm rushing out. And next to that, and if you are going to discuss about the gluconomimetics, if you are going to discuss DPP4 inhibitors and GLP-1 agonists, if you are going to discuss all those things, liraglutide definitely is going to have significant hepatic steatosis. And how many patients we are going to substitute, all those things is still a questionable issue. And next to that, if you're going to use this gluconomimetics, the fat accumulation and insulin resistance, everything is going to improve in a reasonable way. And my intention to discuss with you the very new entity like obeticholic acid and other things, so the new area of newer drugs which is available. And this is briefly about pentoxifylline. If you want to discuss about pentoxifylline, it's a TNF-alpha inhibitor. That is very significant role in alcoholic hepatitis has been initially been made out, followed by some recent study. What they've been mentioned are nothing much of use in pentoxifylline, but even some trials have been mentioned that it inhibits the progression of TNF-alpha, and also it mediates insulin resistance and contribute to the progression. See, what's so this phosphodiesterase is going to contribute to the pathogenesis of progression of NASH. So what's going to happen if you're going to inhibit the phosphodiesterase, inhibits TNF-alpha, it is going to attenuate your steatohepatitis. So there is some beneficial effect. So if you're going to use 400 milligrams TDS, so approximately around 1,200 milligrams of pentoxifylline, some improvement of AST/ALT may be there to consider. And it also increases microcirculation, antioxidant effect, and antifibrotic effect with pentoxifylline being considered. So it can be used, but significant effect are not been proven if you are going to use pentoxifylline for a longer duration of time. And hypertension, if you want to manage in a patient with metabolic syndrome in NAFLD, ARBs is always a preferred molecule, because if you are going to use ARB, there is a reasonable improvement in NAFLD. Also, the ARB is having a good effect on cardiovascular events. Also, it reduces the liver fibrosis, induced portal hypertension, and so many therapeutic implications. Various papers being reported. And PUFA, if you're going to use in compared to the placebo, PUFA definitely is going to have a reasonable benefit. Polyunsaturated fatty acids can be considered, omega-3 can be used, and to a reasonable extent to improve your ALT when compared to your control. And this is very new molecule and most interesting area of obeticholic acid. It's nothing but farnesyl X receptor agonist. So what is going to have? It is going to involve in the bile acid precursors pathway. So what is going to happen? The bile acid pathway is going to be involved and followed by, see, if you're going to use obeticholic acid, there are multiple mechanisms of action. It's going to reduce your fibrosis. It is also going to reduce your inflammation, and it also acts on FXR and RXR, it's retinoid X receptor and FXR sites, and it will be involving in multiple areas. So one, bile acid homeostasis by decrease the bile acid synthesis and decrease bile acid uptake, and increases the bile acid secretion, and also decreases the bile acid absorption. So by various pathways, this obeticholic acid is going to act in your farnesyl X receptor agonist pathway, and this will also predispose to multiple lipid, glucose, and almost all the areas of inflammation is going to come down if you're going to use obeticholic acid at a dose of around 5 milligrams. Some patients we are recommending up to 10 milligrams. Some patients we are giving up to 25 milligrams, and many trials at higher dose being available. But one common side effects, if you're going to think about that, some pruritus, around 20 to 30% of the patients are still being more reported. And there are multiple trials to discuss about this. This is Flint. Flint trial is nothing but non-cirrhotic, non-alcoholic steatohepatitis patient. If you are going to use, what they are going to find out, and see if you are going to use it for a longer duration of time, and the liver histological changes, the liver biopsy, everything is going to improve in a reasonable way, and the decrease, the 2-point decrease in non-alcoholic steatohepatitis with worsening of fibrosis is going to be there, and with no worsening of fibrosis is going to be there. And but always you should remember that some bad news, there is no significant difference in the resolution of NASH between obeticholic acid and placebo groups, and about 1 in 4 of the OCA arms suffer from pruritus. That's what I've been discussing. Pruritus is one common adverse effect being reported. And apart from that, there are nowadays they are recommending as per the FDA guidance, and AASLD is still more approved. And there are, if you're going to combine UDCA, sometimes along with the obeticholic acid, there is some potential benefits for non-alcoholic steatohepatitis to be considered. And this is nothing but regenerate trial in phase 3, what they are going to use by using obeticholic and at a dose of around 25 milligram and 10 milligrams. And if you're going to compare with a placebo, so what's over a period of around over a period of around 6 years. So definitely there should be evidence of some progression. An interim analysis has been made with this study. And next to that, another important molecule that frequently we are using in the management of diabetic dyslipidemia is nothing but it's a novel cardiometabolic agent. It's nothing but saraglitazar. So if you're going to think about saraglitazar, it is having a predominantly PPAR effect. It's nothing but proximal proliferating activating receptor. So what is it? PPAR? It's to be involved in transcription process. So what is this transcription process? They'll be involving in gene modification, regulation, DNA regulation, alteration in RNA synthesis. There are multiple pathways which will predispose to inflammation, steatosis, ballooning, degeneration. So if this pathway is going to not to be manipulated in the proper way, you may land up in multiple complications. That's why the saraglitazar definitely at a rate of around 4 milligrams is being considered in managing a patient with non-alcoholic steatohepatitis. It will be involving in first aid and second aid, and also in the gamma pathway alpha and all the other PPAR as alpha. It is going to be involved if you're going to use saraglitazar in a reasonable way. And all the liver enzymes, there will be a significant reduction in serum ALT and AST. Also MCP. MCP is nothing but monocyte chemoattractant protein. So if you're going to use MCP and all this, MCP, AST, ALT, everything is going to be significantly improved if you're going to use saraglitazar, if you're going to combine for a period of around 8 weeks for in patient to reverse liver dysfunction. So saraglitazar definitely having a potential role. And next to that, liraglutide, if you're going to substitute around 1 to 2 milligrams per day, and it's nothing but it's a GLP-1 analog, but not much of studies to prove the efficacy of liraglutide. And one lean trial what they've been considered minimal resolution of NASH is there, but no worsening of fibrosis if you're going to think about liraglutide. And next to that, elafibranor. It's also one more interesting. See, that's a dual, since saraglitazar is predominantly a dual receptor, and this is acting under 3 forms. Could be PPAR alpha, could be PPAR gamma, and also mainly because of PPAR delta. So once PPAR delta is going to modulate your lipid metabolism and inflammatory signaling, other pathways is going to be involved if you're going to substitute elafibranor to the patient. So elafibranor, you can give it a dose of around 80 to 120 milligrams, can be tried, and over a period of around 52 weeks. And along with, if you're going to see the liver biopsy, there definitely histological activity, everything is going to improve. And elafibranor in RESOLVE IT trial can be considered as a phase 2 trial. And next to that, multiple anti-fibrotic therapies is being tried. And one is by dual chemokinin, CCR2 receptor antagonist, chemokinin receptor antagonist, and nothing but Sensiviroc. It's Senicriviroc, sorry. If you want to look into that, it's primarily targets your inflammation and improves your fibrosis and insulin sensitivity, and also it will be acting on the macrophage infiltration in adipose tissue. CCR2 and Senicriviroc definitely having a reasonable role, but in Centaur trial, what they've been proven that if you're going to use for a longer duration of time, the liver fibrosis and other things can be having a minimal effect as per the Centaur trial. It will compare shorter versus longer CBC treatment and assess the correlation between decrease in inflammation and fibrosis. But it didn't demonstrate a significant improvement in fibrosis if you're going to use Senisiviroc. Next to that, this is another newer molecule, Aramcol. This is nothing but based upon the bile acid as well as based upon the fatty acid pathway, and this is nothing but is ASCD enzyme inhibitors, nothing but steroid coenzyme A desaturase inhibitor. So this is also, it's around 600 milligrams of dose can be considered. What's going to do? It can reduce your storage of TGL and other esters in fatty acid formation, and also reduces the synthesis of free fatty acids. So Aramcol is having a reasonable role, but still more needed clinical data to establish its benefit. So many other drugs like Emricazine have been tried. It's an apoptotic inhibitor, can be tried, but the beneficial effect of Emricazine is not much of use nowadays, and still more trials to be used. And if you're going to block your apoptosis by Emricazine, if you're going to substitute the patient with Emricazine for a longer duration, the duration of time, if you're going to give it a rate of around 25 milligrams per day, it can have some beneficial effects, but still more trials need to be validated to consider that. And next to that, this is also nothing but selonsertib. This is also one more newer entity for management of fatty liver by ASK inhibitor. What is it? ASK apoptosis signal regulating inhibitor. So just remember these names and all, because there are so many new entities being involved in the management of NAFLD. But how we are going to use, whether we are considering this, and there are so many trials to prove that, and still more studies need to be augmented if you want to use these things in managing a patient with non-alcoholic fatty liver disease. And this is one more interesting trial, nothing but Atlas trial. So by Gilead et al. So if you're going to look into the famous person, he has combined 3 major molecules. One is selonsertib, and one is by firoxicostat, and next by cilofexa. If you're going to combine all these 3 molecules, they have been looking into the beneficial effect of steatosis progression and histological activity, whether it is being improving or not. And based upon this trial, that it shows some minimal improvement is there, but still more trials need to be validated to consider this. And one interesting area about gut dysbiosis. See, what is going to happen in gut dysbiosis, always you should remember, if your gut factor is not going to be maintained, there is high evidence of lipopolysaccharide accumulation will be there. Once a lipopolysaccharide is going to accumulate, what is going to happen? Your gut dysbiosis is going to set in. So inflammasomes are going to be activated, the tumor necrosis factor, interleukins, intestinal permeability will be augmented, lipopolysaccharide activation, endotoxemia, all those things will predispose to steatosis and steatohepatitis and fibrosis. So gut dysbiosis is one of the most common entity, and nowadays there is some role of probiotic can be considered in, along with standard medical therapy, can be tried to augment the gut. See, if you're going to look in alcoholic liver disease, not only in inflammatory bowel disease, there are so many entities where there are also probiotic based on gut dysbiosis. The gut microbiota has been taken a separate area of discussion. That's why the gut microbiota has been considered a separate organ system to consider. So if the gut dysbiosis is going to be established, always the dyslipidemia will be there, the worsening of events will be there. The patient can go for other clinical worsening parameters. If the gut dysbiosis is not, gut dysbiosis, if it's going to set in, and if your gut symbiosis, if it is not going to be established. So there are other newer molecules, not much of clinical discussion like money, in recent trials been going on. And apart from that, one thing I would like to discuss with you all, nothing but DMR, nothing but duodenal mucosal resurfacing. See, it's nothing but it's an endoscopic approach. See, if you are going to use this in a patient with type 2 diabetes, what they are going to look into that, they are going to improve your liver fat content. They will be having a significant metabolic improvement. Also, there will be a significant glycemic control is going to be there. So DMR is one new entity being discussed in the newer trials. Through an endoscopic approach can be done. So nothing but duodenal mucosal resurfacing in patient with type 2 diabetes can be considered in managing a patient with NAFLD. So always you should remember, analyze the patient for cirrhosis and hepatocellular carcinoma, because the main cause of death because of multiple events, and liver transplantation is the most important thing. Finally, the patient needs, because by 2025, you're going to look into this. This is going to be the most common indication, NAFLD, for evidence of liver transplant. The 5-year survival will be approximately around 74% post-transplant, and primary cause of death mainly because of, as we all know, also cardiovascular other things. So this is nothing but the overall approach, as I discussed with you. One, diet and lifestyle intervention, vitamin E, pentoxifene and other things, obeticholic acid is having a reasonable benefit. And before concluding, always you should remember, take a proper clinical history to diagnose with the patient on NAFLD, and assess for the evidence of fatty liver, look for the coexisting pathology, rule out other causes, and do a proper lifestyle intervention, and screen the patient for evidence of fibrotic progression, look for the basic markers. If needed, plan for a fibroscan and other assessment, do a AST ratio scan, and start the patient with first-line therapy. If nothing works on, consider the patient for second-line therapy. Control your obesity, hyperlipidemia, dyslipidemia, hypertension in a proper way, and screen yourself in a proper manner to tackle all the problem with non-alcoholic fatty liver disease, and to overcome this epidemic even during this pandemic. That's the most important thing. Before concluding, I would like to discuss with you all. And with this, I would like to rest my presentation, and thanking you all for patient listening. And if there is any question, I'm happy to take over. Thank you, sir.
Very excellent and brilliant presentation, Dr. Arun. You covered almost all the aspects in the fatty liver. You just completed a whole textbook of the fatty liver. We enjoyed your talk.
Thank you, sir.
You covered all the sequences of the fatty liver to the spectrum of other consequences and all, on the epidemiologic incidence and prevalence, and well highlighted on the twin hypothesis mainly. That is first hit with the steatosis and the second hit with the oxidative stress and cytokine inflammation going for other NASH and other fibrosis and the other complications. Well highlighted about that, and well discussed on the clinical association with the global consensus evidences with the, especially with the ASSD and the AAG, because your counterpart is mainly with the American Association of Gastroenterology and American Association of Study of Liver Diseases, and also well defined about the nutrient deficiency. We know only about the obesity, but we miss the topic on the macro and micronutrient deficiency, because undernutrition also is one of the predisposing factor for the NFLD. And also we highlighted well about the caffeine, the benefits of caffeine. Daily drinking 4 to 6 cups of caffeine will have the excellent benefit on reducing the NFLD to the normal liver, because liver is only organ it rejuvenate in quick manner. So, and also you highlighted well about the exercise and NFLD and therapy, especially by ursodeoxycholic acid. It is world renowned therapy by ursodeoxycholic acid. It will express about that. Thank you very much, Dr. Arun. More than that, our India is a diabetic capital country. Here in fatty liver, most of the fatty liver patients will have the association with the diabetes, obesity, dyslipidemia. Almost in FLD, almost 70 to 80% of the diabetic, 70 to 80% diabetic population will be associated with the fatty liver. The sprint trial which was conducted in India by the Indian authors like Sanjay Kaldre, I will clearly alluded that the presentation of NFLD in the diabetic population was around 70 to 80%, and the obesity population more than 90%. So the lifestyle modification, that is reduction in the weight, and please avoid all the lactose, the fructose rich food. Fructose rich food are the main contributing factor for the increased incidence of the fatty liver. So lifestyle modification by means of increased physical activity, weight reduction is very, very important. As you well said that even with 2 to 5 kilos of weight reduction, which is very big benefit for the NFLD, and more than 5% to 10% of weight reduction have the excellent benefit of the NASH. Very excellent presentation, Doctor. We enjoyed the presentation. Thank you very much for
Thank you, sir. Thank you, sir.
The only thing you not highlighted anything about the genetics. We all know that we have 2 types of genetic factor have been involved in the fatty liver. One is PNPLA and TMCX5F2. But the recent ADA 2020 presented a paper on the NREP genetic expression. Neuronal regeneration genetic expression has been presented with the ADA 2020. That is, it was a mouse study. It was a mouse study conducted in the San Francisco. That is with the parental and paternal and maternal parents having with the insulin resistance obesity. Any of the parent like paternal and maternal having insulin resistance obesity, with their linking, the offspring was found to have increased incidence for the NFLD. The main is due to the decreased expression of the neural regeneration of the related protein. What is your opinion on that, Arun?
Definitely, what you said is absolutely true, sir. So genetic manipulation is the most important thing to be considered, and moreover, the PNPLP receptors, the palatin-like peptide receptors, is the most important contributing factor. Apart from that, the insulin resistance, other things to be genetic manipulation is the most important thing to be taken into account, sir.
Because in obesity, we have a lot of data and the thing. See about the skinny fat, that is visceral adiposity. In visceral adiposity, patient landing in NFLD, the genetic factor also may influence important predisposing thing. That only highlighted to you also, Arun. So more than that I'm already highlighted that is snacking, screen timing, physical inactivity are very, very, very essential to be provided, to be nullified, to be rejected. So snacking, defensive snacking or erotic snacking should be avoided. Screen timing, please avoid the excessive screen timing. Watching the TV, watching the mobile phone, sitting immobilization as one of the most cardinal and contributing factor for the NFLD. So with this, I like your presentation. Thankful your presentation, Dr. Arun. So I will go for the question answers by the participants. If there is any question, please post the chat box, delegates.
There are few questions in chat box.
Yeah, there are few questions. The first question was asked by Dr. Morgan, one of a good friend. Does Leaf-52 Woodka endless leaf tablets have any confirmed protective effect in the bedside? His first question.
So UDCA Leaf-52 definitely is not much of use, definitely not recommended. It's over-the-counter medication. The placebo effects has not been considered. Next to that, sir, and if you're going to use UDCA, definitely it's having a reasonable effect, but in patient with non-alcoholic steatohepatitis, the patient's progressing to that, the question of UDCA is definitely not much of consideration. But the one important consideration for usage of UDCA is nothing but PBC, primary biliary cholangitis, where you're going to use a high dose of UDCA. But in NASH, the use of UDCA is definitely a questionable issue to be considered, sir.
So what does fatty liver in ultrasound mean? If patient documents high liver enzyme and increase in liver size progressively, what is the interference?
So if the patient is having high liver enzymes, along with if the patient is having more than 5% of the liver fat accumulation, and if you're going to look for evidence of grade 1, 2, 3 and fatty liver progression, which means we need to confirm the patient with liver biopsy whether the patient is going for evidence of NASH. Once a patient is going for evidence of NASH, we need to look for histological changes like ballooning, degeneration, Mallory dead bodies, and other things like ionization and other parameters to be taken into account before labeling the patient with NASH. But ultrasound parameter alone not be considered to if the patient is presenting with evidence of NASH and other things. Also, we need to consider FibroScan to a certain extent, and the cytokeratin markers also to be considered to a certain extent if it is more validated.
My another friend, Dr. Ramkumar Ramaswamy, has a question. Does liraglutide or dulaglutide halt the progression of fatty liver? What is your experience over there?
I couldn't get you, sir.
Does liraglutide or dulaglutide halt the progression of fatty liver? Your experience over there?
Definitely, when you're going to use liraglutide for a period of time, as per the lean trial, what they've been consumed, that the evidence of histological activity, NASH and other things definitely is going to come down if you're going to use liraglutide at the dose of around 1.5 to 2 milligrams. But moreover, if you're using other potent molecules which is being available in the management of NASH, usage of liraglutide only to consider the management of non-alcoholic fatty liver disease, apart from if it is significantly indicated in managing a patient with diabetes, it's not more indicated, sir.
How many milligram of vitamin E recommended in fatty liver can be combined with death thinners? Another question.
The problem is if you're going to use vitamin E for a longer duration of time, there is possibility few case documentation have been there in evidence of prostate cancer and stroke. But as per the trials, as per the P1s and other statement, if you're going to consider vitamin E along with pioglitazone can be considered, but vitamin E at a dose of around 800 milligrams is more sufficient enough to manage a patient with non-alcoholic fatty liver disease, sir.
Another question from Dr. U.V. Morgan, one of my close friends, sir. Is vitamin E still useful in treatment for fatty liver? Dosage of Woodca in fatty liver? Both the questions.
So dosage of Woodca is not, if you are going to manage a patient with the non-alcoholic steatohepatitis, there is no much of benefits for UDCA. But if you are going to use UDCA, it can be considered at the rate of around 600 to 1,200 milligrams per day if you are going to use UDCA. But vitamin E around, as I discussed with you, around 800 milligrams can be considered. But UDCA, the potential benefits is definitely not there if the patient is having biopsy-proven NASH. Sir,
then question from my friend and by me also, sir. We are practicing physician and diabetologist. If the patient coming with dysglycemia, that is fasting higher and postprandial higher with HbA was elevated, with dyslipidemia, and also a patient has this one ultrasonographic finding of any fatty liver, what are the take-off points? What are the summary? What are the take-home points will be rendering towards that as a practicing physician and diabetologist? What is your opinion? What is your perception over that?
So always, the first thing, any patient who comes to us with the background of metabolic syndrome, as we discussed, dyslipidemia, obesity, hypertension, along with type 2 diabetes, if the patient presents to us with central adiposity, so always we need to see the proper clinical parameters. And next to that, the baseline assessment shows the evidence of fatty liver. We need to categorize the stage of fatty liver, whether it is grade 1, 2, or 3, as per the fatty accumulation. Based upon that, we need to categorize by the baseline liver function test. After that, we need to do a baseline viral screening. Always, if the patient presents to us the evidence of fatty liver, doesn't mean we need to look for other coexisting comorbidities and other complications as to be screened in a proper way before concluding this patient is only because of fatty liver disease. And also you should remember there is one more entity, what is called as lean NASH, that I didn't discuss in my presentation today because it's slightly out of bounds. So what's been lean NASH means even if the patient is lean, doesn't mean that the patient is not having evidence of fatty liver. there is some possibility for them, this kind of patient, that's a new entity, lean non-alcoholic steatohepatitis is also being reported nowadays, and there are more papers being published for lean NASH. And even if this patient is having lean NASH, doesn't mean that only already the patient is lean, if the patient is going to reduce further, is going to improve, nothing like that. But even in this patient with lean NASH, the diet modification, exercise is the most important parameter to be taken into account for consideration. And diet and lifestyle modification with physical activity will take care of most of the patient with fatty liver to prevent the progression of non-alcoholic steatohepatitis. But in India, only 10% of the population is being adhering to those things over a period of 6 months.
So any words on vaccination in preventing NAFLD, sir? Any words on
Definitely, you need to vaccinate the patient for hepatitis B and A, because those vaccinations being available very well. And also you should consider the patient for pneumococcal vaccination, because encapsulated organisms also to be considered. And there are some trials for influenza vaccinations can be considered, but even some case reports for diphtheria and other things being reported, those things and all can be considered. But main thing, hepatitis A and B vaccination is the most important, along with coverage of pneumococcal vaccine is also to be considered.
So among the diabetic patients with the NAFLD, how frequently we have to examine? We have to screen the liver enzyme test once in a
If
6
the patient is having if the patient is diabetic but not having any evidence of non-alcoholic steatohepatitis, if the liver parameters, everything is fine, we can screen once in a year. But even then, if the patient is having nothing, everything, only with the minimal obesity, without evidence of diabetes, we can screen once in 2 to 3 years. But once the patient is progressing to NASH as well as other complications, fibrosis, other things, we need to screen once in 3 to 6 months.
Excellent, sir. We enjoyed the topic, and also we enjoyed all the question sessions. Dear friends, if there are any question, means please share in the chat box so that we will ask Dr. Arun. You will be guiding us, because he is very good in presenting the fatty liver contents. Total book is covered for 1 hour.
Thank you, Dr. Kannan sir, for giving a valuable talk in the area of diabetic and NAFLD, since you're a leading diabetician. So it's a great pleasure for me to be along with you, sir.
Dear friends, more than that, Dr. Arun is my younger brother. He's my own younger brother. Just want to share that.
Yes, sir. Any other questions to share with me, sir?
Waiting for the questions, Dr. Arun. So if there is no more questions, shall we wind up the session?
Sure, sir.
Thank you very much, Sun Pharma, for organizing this, and thank you, Dr. Arun. It's an excellent presentation, elaborate and exponential presentation. We enjoyed all the topics of the fatty liver, all the contents in your style, as usual, a very brilliant presentation. And also, I thank all the delegates, especially in the Sunday evening time. Most of our friends will be very busy with their family. In spite of the busy schedule, they attended almost 60 to 70 participants have been participated in this event. Thank you very much for the participation. Thank you very much, Dr. And thank you, the Sun Pharma team, for this encouragement. Thank you very much.
Thank you very much, sir, for being there in this team, sir. Thank you, sir. Thanks a lot for organizing this event.
Has to close the screen.
Sir.